Good morning, everybody. I'm Kathy Rowe, Executive Director of New Jersey Advocates for Aging Well, and I'm very happy to have our group of age-friendly health system experts with us today. This is something near and dear to me, not only professionally, but personally, as someone who's navigating the health system with an elderly parent with dementia. I have firsthand views of the difference it makes when these approaches are taken with patient care. So we have a lot to cover today. I'm going to turn this over to our New Jersey Advocates for Aging Well board members, Dr. Joshua Raymond and Dr. Vikranta Sharma. Go ahead, Josh.
Good morning. Pleasure to be with everyone today as we move forward with the Age-Friendly Health Initiative. Very exciting. I've been a geriatrician for the last 24 years, training our 18 family practice residents and our geriatric fellow about the 4Ms. So really exciting that this will be taken up from CMS and really hope to help improve quality of health across all health systems. And Dr. Vicky Sharma is also a board member with us.
Hi, my name is Vikranta Sharma. I go by Vicky Sharma. I started out my life in the rural, underserved farmland area of Appalachia in upstate New York, where I received my inspiration from working in under the circumstances where healthcare resources were very limited and people with lesser health literacy. And early on, I recognized the importance of simplifying jargon and paying attention to the small nuances in geriatric population. I don't have a formal fellowship in geriatrics, but I am board certified and a fellow of American Academy of Hospice and Palliative Medicine. I was inspired to go into hospice and palliative medicine after my mother passed with a mixed connective tissue disorder with multitude of complications, and saw on a personal level how intricate and how difficult it can be to navigate healthcare system. And what matters most, mobility, medications, and cognition are foremost in those values that most of individuals, not only just elderly, kind of focus on. So I'm very glad I got an opportunity to collaborate with Hartford Foundation for the 4Ms 3 years ago, and now with the Age Friendly. Welcome, everybody. We are glad to welcome Marcus Escobedo.
I'm just gonna ask everybody to mute. We're picking up a lot of sound. Thank you.
It's my pleasure to, first of all, thank Kathy for all her enthusiasm and energy and focused attention in everything that she works on. It's been a pleasure working with you, Kathy, and walking alongside Josh Raymond has been very friendly atmosphere and opening of the minds and meeting of the minds, if you will, since 2012 that I'm working as a palliative care physician. It's my extreme pleasure to welcome Marcus Escobedo, MPA, Vice President Communications and Senior Program Officer of the John Hartford Foundation. On to you, Marcus.
Oh, great. Well, thank you, Vicky. Thank you, Joshua. And thank you, Kathy. Kathy is a fierce advocate for aging in New Jersey and across the country. I was just on a call with New Jersey Quality Improvement Organization. I mentioned your name, Kathy, and they're like, oh, yes, of course. You know, age friendly and pushing forward better care for all of us as we get older. So thank you for what you're doing. Thank you very much. And I'm glad we're here with my great partners over at the American Hospital Association, and of course, all of you in New Jersey working to improve care for all of us. Let me get going. I'll do a brief, less than 20 minutes, a little bit of a reminder and overview of the Age-Friendly Health Systems Initiative, those 4Ms, talk about that measure that was discussed, and I'll get right in as long as I can get my screen to share. Let me do that. All right. I think that should be showing. So I am Marcus Escobedo, and I am, as was said, Vice President of Communications and a Senior Program Officer at the John A. Hartford Foundation. I have a pretty varied background, and so I was on the program team and actually ran initiatives through our grant-funded projects focused on increasing the geriatrics competence of specialist physicians. And so I have a real space in my heart for ER docs and nurses and staff who work there, and surgical teams that are improving care. I'll touch on those just briefly here too. Let me see if I can get my next slide. The John A. Hartford Foundation, in case you don't know, is a private national philanthropy. We're based in New York City, but fund across the country. Our money comes from the A&P grocery store family owners. We were established in 1929. So if you know the A&P, that's where we started, but we are a private independent foundation today. Our mission is to improve the care of older adults, which is why we're so proud of what New Jersey Advocates for Aging Well are doing, and other organizations like that across the country. We have 3 priority areas that we focus on. We try to create health systems that are more age-friendly. And in addition to the initiative and the movement we'll talk about today, that encompasses many other programs that are also age-friendly and focused on healthcare. We have 2 other areas focused on family caregiving and serious illness and end-of-life care, obviously all overlapping and intersecting areas where age-friendly care is what it's all about. I should mention we fund national organizations and by invitation only. We always like to start with the positive notion of aging, right? Too often in this country, we think of the negatives that come with aging. Ageism, which is discrimination based on age, is still very prevalent and common. And so we try to counter that. We try to tell the story about longevity. That is really one of the greatest success stories of the last century. As we age, we really can help our communities power up with the wisdom, the experience, the connections and community that older adults bring. That requires support, that requires our society to make adjustments to meet the needs of a growing aging population. We need all of society to be what we call age-friendly, which I know you all get here. And so you can see we talk about the age-friendly ecosystem. We need all of our sectors, our public health systems and our healthcare systems, to be adapted and meeting the needs of older adults. We need our workplaces and employers age-friendly, our home and community-based services, our cities and communities, even our education and research sectors. Universities now are becoming age-friendly. And so all of that is important. And for us at our foundation, and why we're here today, is we talk specifically about healthcare becoming more age-friendly, and 3 factors that we like to reinforce and help all of our health systems and hospitals think about. Demography, the growing number of older adults. Those will be more diverse as we go forward. Complexity does come with aging, more chronic conditions, dementia, disability, social isolation, and importantly, the social drivers of health that can all create complexity in our lives as we get older. And we know that older adults experience disproportionate harm in healthcare, right? Whether that's higher rates of adverse drug events, pressure ulcers and falls in hospitals. Also at a bigger level, we have discoordination and fragmentation in our healthcare system that affects older adults who are higher utilizers of healthcare more. And we even have poor preparation for disasters, which are happening too often right now. And so all of that is part of why we have to think about more age-friendly solutions. That's where we have what we're talking about today, in which I think many of you know about the age-friendly health systems movement. This is a social movement so that all care with older adults is equitable, age-friendly care. And we are guided by those essential elements of evidence-based practices, those 4 M's that Vicki mentioned. And so they're here. What matters to the older adult? That's goals, values, and preferences. And are we aligning care with what matters to the older person? Their medications. We know about adverse drug events, polypharmacy, and how dangerous medications can be, inappropriate medications for older adults that need to be attended to. Mentation or mind, which is everything dealing with cognition and mental health, think delirium, dementia, depression, key issues related to older adults and everyone really, but they can really cause harm and need to be attended to. And mobility, keeping moving every day and keeping active in no matter what situation to preserve function and to make sure that we are preventing falls and other harms. So those are the 4 M's, and you're going to keep hearing them over and over through these presentations, and I'll let others go further into them. The essence of age-friendly health systems, though, are to use those 4 M's to reduce harm and to always focus on being consistent with what matters to the older adult and their family. How we came to the 4Ms, just as a reminder and a review for you, in 2016 or so, 2017, we got together, our president, Terry Fulmer, a nurse by background and expert in geriatric care, said, ooh, why do we not have the evidence-based models of care that we know produce better outcomes out more broadly into healthcare? And so thinking about that, gathered experts at the Institute for Healthcare Improvement, a great global quality improvement organization, geriatrics experts across disciplines, and real people like you that work in health systems on the front lines and in leadership. And together they reviewed those evidence-based geriatric care models, found common features, distilled those down into what had the biggest impact for older adults. And that's where we came to the 4Ms. And there's literature and evidence from that you can that are here on the slides that you can cite afterwards. Here's the essence of why the 4Ms. They do represent those core health issues that we experience as we get older. There's a very strong evidence base behind those 4Ms. They do reduce implementation and measurement burden while increasing effect. And so this is not about layering on another program in healthcare, which we know is so busy and so complicated. This is about organizing care around those 4Ms and prioritizing them. We actually think it can make work easier and help reduce cognitive burden in healthcare staff. And the components are really synergistic and reinforce each other. And that's important. They are a set, and you'll hear that, I think, throughout the presentations today. I'm not going to go into detail on these measures for age-friendly care. They're going to be touched on later. My point here is just that these measures that are associated with the 4Ms and the Age-Friendly Health Systems Initiative are measures that you're already collecting in hospitals and practices. So again, it's not adding on more, it's really using the measures that are there and focusing in. I do want to highlight also, there's an important component to age-friendly care about equity, right? Equitable care. And so in the age-friendly health systems movement, a task force was formed, and now and currently participants are, asked to really look at their demographics of the older patients they're serving with 4Ms care, make sure that they're linking that data to quality measures and stratifying by race, ethnicity, and other demographic factors, and then analyzing those outcomes, figuring out where there's disparities, and then taking up follow-up action. So that's a core component of age-friendly care. I'm going to shift now to talk a little bit about the movement and where we are. It's been fascinating. So I mentioned 2017 is when we really launched. And with a growing number of partners, we've just had this takeoff in New Jersey and elsewhere across the country. And so I mentioned the Institute for Healthcare Improvement, helping us lead this with the American Hospital Association, who you'll hear from today. The Catholic Health Association was also engaged with us and are at the beginning. I want to note, I won't go through many of these, but to just note the VA has adopted the 4Ms framework across their healthcare system. The Health Resources and Services Administration, a federal agency, they fund geriatric workforce enhancement program sites across the country. You've got one in New Jersey. They adopted the 4Ms framework. All of these other partners at the state level in AARP, Michigan Health Endowment Fund, just to show that people really are getting behind the 4Ms framework. And so we hope everyone in New Jersey in healthcare will as well. So here's where we are right now with more than 4,000 hospitals, practices, convenient care clinics, nursing homes across the country that have adopted those 4Ms and are really part of this growing movement. And it's gone global too, by the way. So it's really great to see. There's 2 levels of recognition. So for healthcare teams that want to join, adopt the 4Ms, commit to that, submit a plan for how you're going to meet those 4Ms for your patient population, become a participant, get recognized, and we have over 4,000. Going to the next level, collecting data on 4Ms care for older patients gets you to a committed to care excellence level, and over 2,000 sites are there in terms of that additional recognition, which is great to see. We've had more than 3.7 million older adults reached with 4Ms care since the start of the initiative, and we hope New Jersey will keep pushing that even higher so that all our older patients are getting what matters most to them. In New Jersey, really excited to see growth in sites of care, and for Committed to Care Excellence, I know there's more than 20 sites that are there. And so this can be found, there's a link here on IHI where you can download a list and see who's been recognized by IHI. I'm not going to say much about this slide other than to make the point that we're looking at the spread of age-friendly health systems movement, not just at the local level and in communities and the champions that are so important to, from the bottom up, create a movement internally in systems and hospitals around age-friendly care. But at the macro level across the country, through regulation, through payment, through education, certification, accreditation, electronic health records, part of our infrastructure in healthcare, are aligning with other evidence-based initiatives, looking at demand from older adults themselves. All of these are pieces to a national strategy that we're working on to get age-friendly care out to everyone. Here's where I want to make an important, announcement and note for those of you that work in hospitals, or that everyone should be pushing their hospitals, even if you don't work in one, to think about age-friendly care, because it's going to help meet a new measure that was introduced by the Centers of Medicare and Medicaid Services. This was approved and will go into effect in 2025 in January. This is for the Hospital Inpatient Quality Reporting Program. It's one of the programs from the Centers for Medicare and Medicaid Services. Almost all hospitals participate in that. And now, those hospitals that do participate will be required to report on all of the elements within 5 domains that are about age-friendly care. And so the 5 domains are listed here. It's about eliciting patient healthcare goals, focusing on what matters, meeting elements within the domain of managing medications, which is also part of the 4 M's, implementing frailty screenings, that's where you're getting into mobility and mentation. Assessing social vulnerability adds on to these 4 M's, back to what matters. This is, looking at potential elder abuse. What are the family caregiver situation at home, post-hospital discharge? It's those kind of screens, health-related social screens, right? What are the transportation and food needs of older adults that you're caring for? All of this has to be reported now by these hospitals. And finally, really importantly, do you have a team leadership in place that are driving forward these age-friendly care principles within your hospital? So this goes into effect next year. It's a pay for reporting measure at this time, which means that all a hospital has to do to get credit and to get the extra incentive payment that will start coming, and it'll take a while, but in 2027, we'll start seeing those incentive payments attached to this. It's based on your annual Medicare increase that hospitals get every year. There's a percentage that you can lose if you don't report on these 5 domains. So we expect most hospitals won't want to lose that money, so they're going to be reporting. And the trick will be to make sure that we are all telling the story of our hospitals and looking at Medicare Care Compare, where this data will be, to let the public know, how is the hospital reporting on these 5 domains? Are they meeting them? Are they not? And we expect that to lead to a pay for performance measure in a few years, where it will actually be, okay, not just are you reporting and getting that incentive bonus, but are you reporting and getting better outcomes? And therefore, we'll get even more of an incentive payment. So that's where we're heading. And we encourage all of you to really dive into this age-friendly hospital measure, and we'll follow up with links to where you can find more. The slide will go out to you and gives you some more details about those 5 domains, what the specific elements are that are included, and how, again, age-friendly care, the Age-Friendly Health Systems Initiative, can help you meet these. And we have other initiatives as well. But I'm going to save this and not go into in detail, but happy to answer questions later. I mentioned other initiatives that may help you meet that measure. So in addition to age-friendly health systems and joining an action community, which I'm sure will be talked about, and I'll mention more, these are 7-month no-cost opportunities for healthcare teams to get trained up on the 4 M's and join with others to learn how to implement best practices. There are also programs that can help you in specific settings. And these are very important for that measure, which do focus on the emergency department and the surgical departments in hospitals. So 3 that I want to mention. One is the Geriatric Emergency Department Collaborative. This is a training and educational resource. Hospitals can join, their EDs can join, and get training up on 4 M's care and best practices for emergency department care. Related to that, a partner corollary initiative is the Geriatric Emergency Department Accreditation Program. So going through that training then helps you meet standards that have been set by the American College of Emergency Physicians. And again, there's standards here set at 3 levels for an ED that can get recognized, just like you can get recognized through age-friendly health systems, but it's specific to the ED setting and builds out even beyond the 4 M's into what needs to happen for ED care for older adults. The geriatric surgery verification is another similar standards-based program. It was developed by the American College of Surgeons, and it is also around the 4 M's and beyond. And this can help hospitals and surgical teams better deliver quality surgical care that's focused on what matters. A new level is going to be rolled out next year in the surgery verification program that I hope all of you will pay attention to for your hospitals. It'll focus specifically on delirium as an entry point into addressing all 4 M's and moving towards higher levels of verification. So stay tuned, subscribe to our newsletter. You'll see more about that as we roll forward. I'll start coming here to the closing parts of my presentation. I want to make sure you all are aware there is a business case for hospitals and health systems and their practices and nursing homes around age-friendly care. And the Institute for Healthcare Improvement, the American Hospital Association, and others have developed tools that can help you make the case internally for why this kind of care is going to reduce length of stay, it's going to prevent unnecessary rehospitalizations, is going to prevent unnecessary ED visits, is going to get better satisfaction scores on your HCAHPS. So check out these resources. There are links here that you can download and use, including return on investment calculators and issue briefs and case studies that help you make that case. And also the case is coming from your own patients and what we hear every day when they get asked what matters to them and actually have healthcare teams listening. That is an incredible outcome that we think resonates really well with hospital and health system leadership and with the public. And so think about that as an outcome as well. Speaking of outcomes, I won't go through these in much detail, but we do have those. So I just want to highlight a few here from case studies we've got around the country. In Los Angeles, Cedars-Sinai implemented a hip fracture program all around the 4 M's, and they were able to reduce their length of stay by 11%, ending up with $300,000 in direct cost savings. That's something a hospital will listen to if you want to make the case. Providence Health, a really large system focused on their primary care champions, implementing those 4 M's, and we're able to see a 2 to 7% decrease in hospitalizations as a result. And this was based in Oregon. You can read more here, through this case study that you'll get. In a smaller hospital, St. James Parish Hospital, critical access, and this should be for all levels of hospitals and health systems around the country. They too were able to really see the benefit of 4 M's care and get real cost savings, $93,000, by reducing falls with injury and taking these steps around 4 M's care. So please share those messages, think about those, and use that to advocate for age-friendly care. On the slide, you're going to see some ways to get involved and engaged. I mentioned those 7-month action communities. I'm sure AHA will say more, but they are just at the process. This month, they were starting up this next 7-month action community. There will be another 7-month action community that will start in March, and that will be run by the Institute for Healthcare Improvement. You can check out these links to sign up or to encourage others to do so. You can access resources on these sites as well, those case studies, the business case, others. And on October 7th, we'll have a really good call. We call it Friends of Age Friendly, and it's just really broad and open to anyone. You don't have to be signed up or in the movement formally. This next one on October 7th will be really interesting because Michelle Schreiber from the Centers for Medicare and Medicaid Services will be on discussing the age-friendly hospital measure. So it may be of interest to you, so I encourage you to sign up either at ihi.org/age-friendly or at our website. Do go to our website because I think there's lots of great information there about all of these programs, including the geriatric ED program, the geriatric surgery program. We've got many more hospital at home, family caregiver support programs that actually use the 4 M's to care for caregivers who come in with the older adult. All of this you could scan and go to our URL, subscribe to our newsletter, and you will stay informed and keep up with us at the John A. Hartford Foundation. I'll thank you there, and really look forward to partnering with everyone around the table here and really work towards helping New Jersey continue on its leadership and its momentum to make sure age-friendly care is there for all older adults in New Jersey. So thank you, and I will turn it back to the agenda.
Got you. You know, Marcus, this is Josh Raymond over here. One of the things that really impresses me is maybe the quality that the age-friendly system facilitates. And I'm just curious, is there an association with the star ratings, 5-star hospitals and age-friendly hospitals, or is there a correlation with that?
It's a great question, Joshua. And there's more research happening to look. That question has come up and is being explored. We've just funded a new research center at UCSF, University of California, San Francisco. And they're looking at those questions right now. And they've just begun publishing some papers. And so stay tuned. We expect and would think we will see those kind of correlations, and like, hey, I will mention one thing we did see. We did a consumer, a public survey, and it was fascinating, and I'll share that link too. But we saw that older adults who received 4M's care, and when we asked 2,500 older adults, their ratings of their healthcare provider relationships and their own personal health state were so much better than those older adults who reported not receiving 4M's care. So I think that's leading to some of this on that side, as well as the star rating side.
For sure.
And I think from a hospital administrator standpoint, I think that affects your bottom line, right? With your HCAHPS scores, your readmission. So really, in my opinion, gives a true incentive. But more importantly, it really sounds like that's what matters, huh? Right, to the actual patient, if we go back to that as the center.
Right.
So yeah, thank you very much.
Kathy, are you having Q&A now, or would you prefer us to hold our questions till the end?
Okay.
We actually are a couple of minutes ahead of schedule. You know, we talk
Oh.
fast in New Jersey. So, Julie, if you have a question, we could take one or two before we move on to Atlantic Health.
Okay, thank you. Thank you so much, Marcus. It's so important to get the word out about the advances that are being made with this program, and it's very encouraging to hear that so many other systems are now paying attention and helping, you know, make those goals be a reality. One of the things that I think about a lot is how this work and the vision that the Hartford Foundation has had, and now other hospital administrators are having, how it intersects with the gaps we have in the workforce. And I know that that's an important issue that Hartford is also focusing on, the care economy. And I just wonder if you think that some of these new incentives and measures from CMS and others are going to help with that problem and maybe create a bigger ecosystem of support all the way around, because I know from my own experience with my family members that that's a big part of the quality of care in any healthcare setting. And so I'm just thinking how that all intersects with each other.
It's a great point, Julia. And I do think there are intersections, just as you're suggesting there, through the age-friendly ecosystem in all sectors and all parts of healthcare and long-term service and supports. Really thinking about age-friendly care, what matters to the older adults, and meeting our specific needs as we get older. On the healthcare side, we've been wrestling with, you know, the lack of geriatric specific specialists. And our foundation has worked for decades trying to get more geriatricians, geriatric nurse practitioners, geriatric social workers, and just kept running up against systemic challenges there. We think the 4Ms and training on that and the movement around age-friendly health systems helps bolster the workforce by focusing on everyone having basic geriatrics competence. Then when we move into things like home care, family caregiver support, the aides that we need in nursing homes, community health workers. We just had a project with the National Rural Health Association taking 4M's training to community health workers in Texas, certified by the Texas Department of Education, Texas Department of Health, and rolling out 4M's care through those CHWs. So adding to the workforce there. So all of that comes together, Julia. I think it's a great point and something we help age-friendly care can promote.
Thank you.
And I'll just add that I can share a little bit more about that in my portion as well.
Great, Rahat.
So, more questions?
I have a question. I know some of us are very concerned about the cutbacks in Medicare reimbursement, which is really going to be the countervailing force to doctors spending more time with patients and asking the questions and listening to the answers that we're talking about. Is there any effort being made to work in that regard so that we don't see that countervailing force?
No, it is right. So much depends on payments and policy and reimbursement systems, and we've seen. So the answer is yes. There's work at the federal level around policies that really can better support age-friendly care, and reimbursement issues are tricky. They're there. A couple of things have happened over time. New codes have been introduced in fee-for-service Medicare that better, support age-friendly care. This new measure that will provide some financial incentives to hospitals is one place where we're going to see some ways where some increases could help in terms of finances and supporting age-friendly care. But we are working with our federal partners, looking at that. And I think in some ways it could lead to changes. We know, like this is not a policy issue, but minute clinics across the country with CVS pharmacies, they adopted the 4Ms framework. And as they started rolling it out, they realized, well, if we're going to really achieve the outcomes, we need more time in our visits. And that they extended their visits for older adults by 10 minutes because they saw the financial return on it. So we're hoping that at the bigger level with Medicare, we'll see something similar.
You're muted, Kathy.
I thank you.
Should I go ahead and introduce our next speaker then? It's my privilege to welcome Dr. Kirti Sharma, MD, MPH. She is the Chief of Geriatrics System and Associate Medical Director of Geriatrics, as well as the Fellowship Program. It's one of the hospital systems in New Jersey that does have a geriatric fellowship program. She's also the medical director for Atlantic Visiting Nurse Service, and also her partner, Brittany Daly, DNP, RN, and CCRN, who is the director of nursing medicine at the Morristown Medical Center. Thank you.
Thank you, Vikranta, for that kind introduction. So I'm going to share my screen, and I think I can't see you guys once I'm sharing, so please speak up if anybody has any, or the presentation is not going appropriately. So hopefully, let's just go into. Are you guys seeing my slides?
Yep, looks good.
Perfect. Thank you. Thank you, Kathy, and thank you, Josh and Vikranta, for this opportunity to speak at this event. So it's my great pleasure to talk to you about the age-friendly initiative here at Atlantic Health. So for my intent is that in the next, between me and Brittany, in the next 10 to 15 minutes, we'll kind of give you an overview of Atlantic Health System sites in New Jersey. Most of you may already be familiar with that. We'll briefly speak to you about our motivations to have this system-wide implementation of the 4M framework. Discuss with you the journey at Morristown, because that's our flagship hospital and that's where most of the activity is happening, though we want to emulate that system-wide. Discuss some results that we have seen and outcomes we have seen in the units where we have had the longest experience with the 4M rollout. And then finally, how this initiative has actually helped us do other things within our health system to improve the care of our aging patients. So that said, for those who may not be familiar with Morristown, this is the hospital front. So, I would like to actually start by saying that we at Morristown and throughout Atlantic Health System do take great pride in providing high quality, innovative, and personalized healthcare. And we are truly humbled by the recognition that our medical centers have received both regionally and nationally as we offer health, hope, and healing to the communities we serve. So what I'm sharing here is pretty much not only just the recognitions, but our commitment to providing care which is aligned to our older adults. So by seeking the niche designation, I think, which was probably the earliest designation we had within our hospital, and now many of our system hospitals, we realized that the workforce we have within our nursing needed to improve the caliber of care that they were providing at the bedside to our older adults. Followed by the geriatric ED recognition as a level 1 Geri ED, and then most recently our partnership with the age-friendly health system, the wave of age-friendly health systems. This is, so at Atlantic Health, we have 6 medical centers. You briefly saw Morristown, including a children's hospital. We also have a close partnership with Central State and St. Peter's Health System. We are part of a large accountable care organization, probably one of the largest in the United States, with over 18,000 team members, including 4,500 physicians that manage about 1.5 million patients. Outside of our medical center footprint, we also do have geriatric outpatient practice, which is called the Geriatric Assessment Center, located in Morristown, which is a state-of-the-art geriatrics practice providing both primary care and consultative services, and taking a lot of pride in having a multidisciplinary approach to caring for our older adults. So the practice has social workers, licensed clinical social workers, physicians, nurse practitioners, and close partnership outside of that with our home care agency and also with our physiatry services to ensure that we are able to provide that person-centric care. So the reason I share this with you is because if you were, as Marcus has shared with us, to go to the AHI's age-friendly health site and try to see which Atlantic Health medical centers sites are recognized as age-friendly, you will pretty much see most of our hospitals. The one hospital out of our primary hospitals that take care of adult patients that's missing on this list is Chilton, which is in the process of putting the framework in place to ensure that they can get on to incorporate this initiative. And my understanding also is that Central State, that's a close partner, is now an Atlantic, is an age-friendly participant. Now, that said, the question always comes up is, what was our motivation? So I would actually start by, even before I explain the slide, I would say one of our largest motivation when we started, when nobody knew, we were probably in the second wave to take on this, but I think the biggest nudge came from our leadership. And I would like to acknowledge that as health systems, it's so important that for leadership to very early recognize that this is something they want to do. This is what they think as an important partnership they want to facilitate, just so that their team members feel supported as they roll out these initiatives. So, of course, the hospital president, the health system president, CEO, and the hospital president were all extremely supportive. And what they were seeing at that time is what all health systems are seeing, that if we are going to be in this business, we will take care of a lot of older patients. And since our populations are only going to age, we might as well do a better job of what we are doing. So within Atlantic Health System, as you see in between 2021 to 2023 itself, where we took care of more than 200,000 individuals who within the hospital itself who were actually hospitalized, and about 61% of them were over 65 years of age. Now, given our footprint in New Jersey, if you were to look at the left of this slide, you will see that our medical centers serve many counties in northern, western, and central New Jersey now, especially with our partnership with Central State. We do feel that there is a significant aging population in this area. So if we are going to be in business in these communities, we do have a responsibility to provide this high level care. And with that, I also want to mention that we are a high reliability organization. So given the HRO designation, we also are committed to initiate improvements and begin to study, measure, and change, and also to study change and apply new processes to make sure that there is improvements that are constantly being looked at on an ongoing basis. So with that, I'm going to ask Brittany to come in and speak to us as to how was our journey, because I think many people would be interested in understanding if the journey just started hospital-wide or did we do slow steps. So Brittany.
Hi, good morning. My name is Brittany Daly. I'm the Director of Nursing for the Medical Services at Morristown Medical Center. So as Dr. Sharma was saying, here you can see in 2019, we really started our journey. The first 2 units were Con 4 and Con 5, which are medical units, high geriatric patient populations. And you can see over the course of this 5-year journey, we really have expanded every year 2 additional units, not only inpatient, the Geriatric Assessment Center is an outpatient center. The units in green are surgical units, and the units in red are cardiac units. So we really were intentional about how we rolled it out. And as of 2024, we are rolling it out at all of our sites as well. So that was a great implementation strategy for our organization. Here you can see our longitudinal 4Ms implementation on those original 2 units. So we've had the longest period of time with those 2 units, so we'll be referencing some of the positive impacts we've seen on those units in the next few slides. So here you can see the overview of the progression and compliance from 2020, where we were achieving all 4Ms in 86% of the instances, up until 2023, where we were able to achieve all 4Ms 100% of the time. So during that period of time, we really looked at how are we identifying our opportunities and monitoring compliance and revising and evaluating how we were implementing each of the 4Ms. Here you can see, using the National Database of Nursing Quality Indicators, we can really see a positive impact on our fall rate on those, again, original 4Ms units. So the trend line is clearly going in the downward direction, noting a fall reduction. Through all of our age-friendly initiatives, we were able to implement addressing proper medication management, increasing mobility with our mobility technicians on our units, as well as identifying patients at risk for delirium and mitigating any safety risks they may experience. So through all of those efforts, we have been able to support patient mobility and functional status while successfully maintaining their safety. So as we noted in the previous slide, it was really important to ensure that we were addressing their mobility status and maintaining that functional status through their hospitalization. So here you can see that these same units were able to discharge patients to the same or improved level of care upon discharge. So Unit 1 improved their discharge disposition from 50% in 2018, being discharged to the same or improved level of care, to 75% in 2023, and Unit 2 improved from 52% to 66%. So again, our goal is always to discharge our patients that were admitted from home back to home, rather than to discharge them to rehab. And this is really an interdisciplinary effort to maintain their functional status during the duration of their stay.
Brittany, sorry to interrupt. Can you remind me what is Unit 2?
Unit 1 and Unit 2 are Con 4 and Con 5, those original medical units that we started on.
So the drops are from COVID experiences, or?
Can you go back, Dr. Sharma, to the previous slide? So yes, so you can see 2018 really was a pretty true baseline, the 52 and 50. We did have, as with majority of the health systems, a gross increase, the 78 and 71% from the COVID timeframe. The 54%, we did have a drop there in 2021, where we were, we had a vacancy in one of our mobility technician positions, and so that did impact our ability to continue to mobilize them. But since then, we have continued the trend upward for that unit too. Thank you. Okay, thank you. So for what matters here, this really is an interdisciplinary team effort, but we did have an increased focus on nursing documentation for that what matters conversation. So we were confident that the conversation was happening. We were having crucial discussions on what matters to the patient. However, the documentation was not always readily available across the interdisciplinary team. So in order to address this, we did incorporate this into the nursing documentation and assessment process. And between 2020 and 2023, we were able to generate a smart phrase in Epic, which permitted easier documentation for the team to document these conversations that were shared amongst the interdisciplinary care team. And these conversations and documentation were then able to be, everyone was able to view them so that we were ensuring that we were all focusing on the same patient goals. Here, we did also see that our likelihood to recommend scores are continuing to move in a positive direction on these original units. So our definitely yes and probably yes scores are continuing to go in a positive direction. Some additional age-friendly accessories that we have been able to implement and utilize for this very important patient population include the Niche Take Care Therapeutic Activity Kit. So as you can see, there are baby dolls and coloring books and some other pieces of tools that are distractions and can help support our patients when they're in a new environment. Also, we ensure that all of their patient belongings are easily accessible, and we are tracking them at every point of their stay. So their hearing aids, their glasses, dentures, all of those very important tools are in these belonging containers that are utilized on all of our units. Additionally, we did purchase sound amplifiers as well, so that patients who were hard of hearing, if their hearing aids had been left at home or anything, that we could also support them while they were in the hospital until those tools could be brought in. So we also identified through one of our internal committees, our workplace violence committee, that there were times where our geriatric population does present some safety concerns to our team members as well. So we really utilized the workplace violence committee and partnered with our strong geriatrics program and started to brainstorm some alternative ways that we can help de-escalate this patient population and increase the safety of both the patient and our care team. So what we were able to do, which was to partner also with our hospital elder life program, who helps to train team members, and they are also going to the bedside of our geriatric patients. We use the niche tools and resources. We also have a Soothing Pause pet therapy program that we utilize to help calm our patients, as well as additional staff training on specifically geriatric patient populations and how to de-escalate those challenging situations. I'll turn it over to you, Dr. Sharma.
Thank you so much.
So all in all, I think what's important is that, not only becoming cognizant of our need to be providing care that's along the 4M initiative, we realize that, in so many ways, there is so many things that we can do as a health system to not only improve the care of the care that our patients receive, but also elevate the abilities of our own staff and our team members. So our intent, of course, is into the future, not only ensure that every single unit within the hospital, just not our inpatient areas, but also the ambulatory areas within the hospital are all designated age-friendly, but all of our nursing assistants, patient care techs, mobility techs, safety coaches have been educated about the age-friendly initiative. We do have, with our niche initiative, have a robust program within the hospital to ensure that our RNs get certified in geriatric care. So there's been a significant push supported by Brittany and our chief nursing officer to ensure that more and more of our nurses get engaged and become more cognizant of providing using this framework in the care they provide. And what I want to share finally is what Marcus actually just talked about is the CMS reporting requirement as of January 2025. So in the last 5 years, even though we have been so slow and steady and been spreading the word throughout our hospital and now into our various medical centers and health partners, we have realized that being an early adopter, we are kind of finding ourselves in a position where we are hoping that we would be successful in meeting this requirement as it rolls out in January. So hopefully we have all the tools that will help us elicit these healthcare goals by partnering with our nursing team members. So this can not just be a physician-driven process. It has to involve every member of the health team, which could be sometimes our social workers and physical therapists on the unit also who help us identify. But I think the initiative Brittany talked about, led by nursing, has been extremely successful. Our ability to responsibly manage medication, so looking at even additional tools to partner with pharmacy to ensure that we are not using these high-risk medications in this population. We already have incorporated the frailty screening and intervention. We are looking at the social determinants of health in all our care areas to identify our high-risk populations. And of course, we do have a team of highly committed leaders within a health system who will ensure the delivery of this care. So I would like to acknowledge all our team members because this work cannot be done alone. So we having support from the top and all the way to the bottom of our team. We have many of us engaged every day to ensure that we are providing this care. And even though the reporting from IHI or the data collection is supposed to be, say, in the last quarter, we are monitoring this throughout the year to ensure that we never lapse on providing this level of care. So with that, this is our contact information. And I'm not sure if you'll wait for questions to the later part of, and I'll stop sharing, Kathy.
That was wonderful. I do have a question for you, but I will leave whether it can be answered now or at the end to Kathy, because I know that time is limited and we have wonderful speakers ahead as well. Thank you so much. It was very informative. My question was basically about the starting of the unit and what the staffing was to start with and how it has evolved.
I'll just briefly do it and then I'll allow Brittany to speak to it because she, so the initial units that we started on were our 2 med-surg units that have the highest density of our older population. So one of them was a general, I would say a medical unit more, the K4, and K5 actually was our neuroscience unit where we saw a lot of stroke patients. Both of these were under Brittany in some shape or form. And I think that was the initial motivation to keep it consolidated, keep it under one leader. We in all these units, we had mobility experts, mobility techs, which means that outside of having waiting for physical therapy to mobilize patients, we had, and Brittany probably can speak to that. Brittany, let me allow you to speak. Let me not take it under.
No problem. You were doing a great job.
Yes.
Yes, we do have mobility technicians on both of the units. The mobility technicians did start on Con 5. We expanded them to Con 4. Their purpose is solely ambulation. So they are ambulating patients up and down the hallways multiple times a day, really trying to maintain their functional status. There are techs on the unit as well. They help. We had an out of bed for meals initiative, right? We eat breakfast out of bed, so should our patients. So we really got a lot of traction with that mentality. And patients were up out of bed by 8:30, all of the patients, so that they could be up and eating and then start their day. This also helps obviously with, regulation and day-night, orientation, all of those things. So pulling the blinds, all of that kind of went along with just maintaining, mobilizing them in their day-to-day.
Okay. Were there any designated pharmacists to those units?
There was a period of time that we did have an area-based pharmacist, that dissolved a little bit during COVID, is starting to come back. But for the duration of the time, there wasn't a dedicated, one for the entire period of time. But there are, area-based pharmacists that do help support, to support this initiative across both of the units. One pharmacist covers both of the units.
In addition, I think what we have within EPIC is best practice advisories that are linked to prescribing certain medications and certain dosages. So I think that was built into EPIC already and that was hospital-wide, even on units that at that time were not part of the 4M framework. So that was allowing us to educate physicians on a regular basis, just to kind of, trigger that as soon as they started to prescribe something which was potentially high risk or was at an inappropriate dose. Now, I do see a question from Kathy asking us if they were, or from, let me just see who it was from, that if there were any challenges. I do want to be transparent with sharing the biggest challenge we had, and Brittany will echo this, was with documentation of what matters. So we realized that even though we were having these conversations, we did not have, and initially we had only utilized having a goals of care discussion or advanced care planning as the only tool. And Brittany, probably you want to speak to our journey with making sure that we included that as part of nursing documentation and capture that as to how we
So
did that.
did. I did allude to the fact that we developed a smart phrase. If you're familiar with EPIC, you can do a dot phrase. It was dot what matters, and it populated a series of questions. The questions had originally existed on physical paper, that we would have conversations with patients. We converted that into the smart, the dot phrase in EPIC. It goes on the treatment team sticky note, which again is visible to all team members, not just nursing and or providers. So you really could see what the ongoing conversations were with the patient, and anyone could input additional information into that as well.
Thank you so much. Kathy?
Okay, I think we're ready to move ahead to Teresa Edelstein.
Sure. Can I give the introduction for that? Thank you very much, Kirti. That's really, it must be a pleasure to work there. I bet your employee satisfaction scores have improved as well up at Morristown with people that work on those units. Our next speaker is Teresa Edelstein. She's the Senior Vice President for the Centers for Partnership Transformation Health at the New Jersey Hospital Association Autumn Branch. She is the Program Manager of Population Health at the American Hospital Association, and the Rahat Ansari, Senior Program Manager in Population Health with the American Hospital Association, and she'll be speaking to us next.
Thanks very much, Dr. Raymond and Kathy. I'm going to lead off our small group here. And as Dr. Raymond said, I'm one of the senior vice presidents at the New Jersey Hospital Association. I've spent my entire almost 40-year career in the field of geriatrics or long-term care. And I will say that the New Jersey Hospital Association is very supportive of the age-friendly health system initiatives taking place in our state and around the country, but also the age-friendly communities and other age-friendly movements that are taking shape and taking hold. What I wanted to do just with a few minutes at the top here is pull the camera lens a little bit further out and really talk about some of the underlying issues that we need to think about as we are educating, training, and supporting our teams to implement age-friendly health systems. And really, and Marcus already spoke to this just a little bit, the underlying ageism in American society is very much alive and well, and is something that if you've grown up in this culture for any period of time, we have all integrated into our psyche and may not even realize sometimes that we have some of our own ageist attitudes in play. And even for those of us who work in healthcare and in aging services, we are prone to those ageist inclinations also. So what I wanted to just do today is remind us of that and talk about some of the ways we can incorporate reframing aging into the work of age-friendly health systems. And we're really at a great pivotal time because we have a strategic framework for a national plan for aging that has been released by a group of federal agencies led by the Administration for Community Living. And we also have New Jersey's Age-Friendly Communities Blueprint. So a lot of things are coalescing at the same time to support changes in attitude as well as changes in practice. So I will talk just for another couple of minutes about how we change the language we use when we talk about aging, our own aging, as well as that of the patients and communities we serve, and what kinds of strategies we can adopt to be successful in reframing aging, both in our home and personal lives and at work. So Kathy, you can go to the next slide. So I'm not going to spend a lot of time on this slide. You can delve into it a bit more when you receive the slide decks, but ageism exists on multiple levels, the interpersonal level, the cognitive level where we stereotype based on age, the emotional level where we may express prejudice in one way or another, and behaviorally in acts of discrimination against people because of how old they are. And one of my mentors, Dr. Robert Butler, defined ageism many, many, many decades ago now as the systemic stereotyping and discrimination against people because they are old. And I think we can all identify situations in the healthcare environments wherever people are in the healthcare environment where ageism does play out. And it can have a very damaging effect, as we have already heard, on the type of care or the lack of care that our patients and our communities receive. You can go to the next one, Kathy. So earlier this year, Stacey Torres wrote a piece for the LA Times where she talked about ageism and talked about how age matters, but so do the words we use surrounding age. So I just pulled a couple of key things out of her article that I thought would stimulate some thought and some recognition of ageism and how it plays out in society. So Ms. Torres said, older people aren't the issue, but the way we talk about them is the issue. And we need to change our language in terms of how we describe older adults. And in healthcare, and especially I think in acute care settings, this is really difficult because we see the frailest of the frail, the sickest of the sick. So it's hard to remember sometimes that there's a whole group of older people out in communities who aren't frail, who aren't sick, who are thriving, contributing, and even frail and sick older people can contribute and thrive with our support and our help. She argues that the word elderly is a word we should sort of take out of our vernacular. because it conjures up those images of frailty and helplessness. And we should really use the term older adult in all of our work. She points out that ageism is a pretty widely accepted prejudice. It defies political persuasion. Everybody picks on older people, it seems. If you think about the last time you bought a birthday card for someone who was maybe over 30, it doesn't take long to figure out that you can't really find one that's celebrating the fact that someone's getting older. It's making a joke about it, perhaps, but it's not really celebratory. And this kind of bias doesn't seem to bring out the kind of outrage that we hear about other types of bias, and rightly so, of course. So when you get to the issues of equity, if you think about someone who's lived their life facing issues of inequity for other reasons, once they become older, that just piles on top. And so it's really gratifying to see the focus on equity being brought into age-friendly initiatives. So I'm challenging all of us to really think about, when we wake up in the morning and we look in the mirror, we are another 24 hours older. What are we saying to ourselves when we look in the mirror about our own aging, about the fact that we are contributing and still have purpose and have a mission? And how can we portray that out in our work and in society? Next slide, please. Kathy? Okay, so I am trained by the National Center to Reframe Aging as a facilitator for their curriculum. So if anybody's interested in that, happy to talk to you offline about that. But I thought it was helpful for you to have this slide to point out why we need to reframe aging. You know, those of us in aging or healthcare, we tend to embrace these issues, as we've all heard so far already, but the public doesn't have that viewpoint, and we are all part of the public as well. So maybe we have a special obligation or role in bringing out the need to reframe aging in society at large. Next slide, please. Next slide, please. Okay, so I'm just going to leave you with this as a way to spark your thinking. We should make a concerted effort, a real conscious effort, to talk about the process of aging as another part of the life development cycle, as a way of building momentum, continuing to have purpose, and really broaden out the conversation to explain, and Marcus mentioned this, explain the supports we need in the ecosystem to live meaningful lives as we age. We should strive to talk about frailty, but without a paternalistic overlay, and talk about ageism as a problem that can be solved. Let's get away from the aging tsunami imagery, because if you think about a tsunami, you think about drowning, you think about being overwhelmed, you think about no way out. There is a way to deal with ageism and aging, and we are all creative people, as we've heard so much already, and we can apply that to ageism as well. So I am going to turn things over now to my colleagues at AHA to take it from here.
Thank you so much, Teresa, and thank you all for the opportunity to join you all today. So I can just do a quick intro as the slides are coming up. And thank you, Kathy, for helping me to share those. I did have a bit of tech issues earlier this morning, but we made it. And you know, what's a Friday morning meeting without a little bit of tech issues? So my name is Rahat Ansari. I am Senior Program Manager with the American Hospital Association, and I've been directing this work, the age-friendly work within AHA, for many years now, since 2017. Worked with Marcus on for many years now, and on these slides as well. So you're going to see a little bit of overlap and a little bit of reiteration, and really that's just to drive certain points home. But truly, you all have heard from the experts already, and you know, with Atlantic Health, we have brought them in to share their story and their data. And so I bet all of you are wondering now, how can I replicate this at my own organization. So I'll just kind of start off by a little bit of foundational within AHA, and I'll just spend most of my time kind of going over the practicality of bringing this to your own organization. So we can go to the next slide.
See, Rahat, is it showing fully in the screen?
It's yes, it's showing on my end at least. I hope you all can chat in and let us know if you're having some issues with the slides, with seeing the slides.
We can see you.
So just to start off with the mission and vision. And this is actually something that we're beginning to teach now, that we understand getting leadership buy-in can be a challenge, that just taking a pause and tying it back to your organization's mission and vision, and also aligning it to the strategies, which I'll spend some time talking about right in the first few slides. It is very important when you can speak the language of your leaders and understand their concerns and share how age friendly can alleviate some of those challenges that they're seeing. That's going to be a huge draw in being able to successfully implement this into your work, because we know that there are going to be challenges, and with having leadership behind you, you can work through those challenges together with their full support. So just to kind of start off by sharing AHA's mission and vision, we're here as AHA to support our member hospitals first and foremost, as well as the healthcare field. We're committed to providing equitable healthcare, which is what we just heard about, right? Supporting that older adult population very much aligns with that equitable care. So we're committed to improving equitable care and health improvement for all. So obviously, when the opportunity presented itself from the Johnny Hartford Foundation, Terry and Marcus, thank you. We knew that it was just the right thing to do. So we can move to the next slide. We'll just talk a little bit about the big picture here within AHA. So mission and vision is very important, and your strategic initiatives, just kind of making sure that you take that time to align the work that you're trying to do with what your organization has prioritized. And I'll just touch briefly on these because I'm sure the alignments are pretty clear, but I know the font might be a little bit small. But this age-friendly work works to enhance care and provide greater value. It has the potential to support financial stability. I know we heard some financial outcomes. Marcus shared some, and I believe Brittany did as well. And so the third thing is, when treating patients, you want to make sure, obviously, that we're treating with respect and provide, and that ultimately can have some better health outcomes. All of this care can enhance public trust and confidence. Workforce, I know we heard that question, and it's something that is obviously top of mind for many organizations right now. But we have heard from many different individuals the different ways that this work has impacted the workforce. And I can just pause and share a few examples of bringing in the team and getting everybody on the same page. And one of the first things that we do within our action community, which I'll talk a little bit more about, there's so much to share, which I'll talk more about in just a moment, is you take a moment to assess all of the work that you're doing and that is already existing. And you take a moment to understand, what do you want to continue to do? What is absolutely essential and vital and makes sense? And then on the flip side, what are things that we should probably consider not doing anymore? Is it duplicative? Is it not helpful? Is it high effort for low reward? Is there a different way we could do it? So by taking a moment to assess all of this programming that currently exists, a lot of times organizations are able to free up some additional time. So while you might assume that it could take additional staff time for the long term, it might take a little bit of additional staff time initially to get it started, but ultimately you should be able to eliminate some unnecessary processes with that. And then secondarily, with workforce, one thing that I really wanted to highlight was the impact that it's had on providers. And we've heard firsthand that many providers get into caring for older adults, get into caring for patients, because that's something that they are genuinely interested and they want that time with those patients. And some providers have found that, there's no time, it's a lot of paperwork, and, there's no time to really connect with their patients. But this 4M's framework of bringing that what matters specifically to the forefront of these conversations, and how what matters dictates the medications, the mentation, and the mobility, that we've heard the reinvigoration that comes to those providers through being able to practice and having that time with their patients and really getting to know them. So just wanted to share that as well. One additional important initiative that the AHA has recently launched is called the Patient Safety Initiative. And this is a really great way to reframe some of the aging. So we've been able to build the aging work within that. And so Patient Safety Initiative has three key buckets right now. It's really focusing on the culture of safety all the way from the board to the bedside. So whoever's interacting it to whatever capacity, direct, indirect. So that's one. Identifying and addressing the inequities and focusing on creating a more equitable space. And of course, enhancing workforce safety. So with this other really big initiative happening and marrying that with age friendly within AHA, we've seen a large amount of success with being able to share on this work. So I will continue on to the next slide. And again, I think Marcus touched on this, and I know we are running short on time, but you all understand the reason why it's important to focus on this older adult group, and what the opportunity is here. So we can move on to the next slide. Marcus also did touch upon this, but I can just highlight this because it's a very important piece that, well, what is the age-friendly health systems? We're working to implement the 4Ms. It was an evidence-based structure that after a lot of research was worked to being implemented, and it is ready to, it's a package that's ready to be implemented within other organizations, within all organizations. And the very interesting thing here is that it can be tailored to meet any organization's needs. And I know we heard Marcus share a few different types of organizations and the case studies that he quickly went over. And it truly, you can tailor it to fit your organization's needs down to your unit levels needs, and which is what we teach in our 7-month action community. So I know that's probably the crux that you all want to hear about. And the one other thing that I do want to share is that while this work is a package, I did love hearing Brittany and how they were tracking how consistently they were able to see through the 4Ms at a whole. And we understand that even though this is a package, there isn't going to be, every single day is not butterflies and rainbows where you're going to be able to succeed for all the time with every patient. So just love how real what an organization might. And we'll kind of go over the goals here.
I'm having a hard time hearing.
Rahad, you were breaking up a bit. I think she froze.
I am sorry. Can you all hear me okay?
Yes, now we can. Thanks.
Okay, great. See, I wasn't lying when I said I had some tech issues. I'm still having them. So just wanted to go over quickly what our goal was, but this is a social movement. It's not just an initiative, it's a social movement. And our goal is to ensure that all care is age-friendly care. Guided by the essential evidence-based practices, the 4Ms, it causes no harm, and really is consistent with what matters to that older adult. And that is so key, and you've heard me already share a little bit about that. Our aims, just really quickly, were met and exceeded. We know we blew all those out of the water, and we'll continue on down to see some more stats on impact. Great. And so this is just a quick map of how we met our goal. The fact that we met our goal, you know, we initially thought that by 2023 we would have approximately 2006 or 2000, I would say, healthcare organizations, but we exceeded that and surpassed that by a lot. We're in all 50 states, and we're even international. And so I'll talk a little bit more about what the two designations mean, right, which is what you see here. But for over 4,000 have achieved level 1 recognition, which is the participant level, and over 2,000 have achieved level 2 recognition, which takes a little bit more effort, and we're here to help you through all of that. So I'll keep on moving so you can see some of the next steps, which is right here. So our 7-month action community is a virtual, mostly virtual learning collaborative. And so we, as Marcus said, we're still in the tail end of our recruitment phase. And actually, I think we might have, Marcus, so great news for you, hot off the press. We might have the largest group to date with 187 teams registered as of this morning. So there's a little bit more time left to join us if you're interested. And I know my colleague Autumn is on, and she can chat in a link if you are interested in getting more information or going directly to our form so that you can sign up and register. But I'll talk a little bit about what you'd be registering for. 7-month long of the virtual learning collaborative with one in-person meeting. And each month we have 2 sets of webinars. One is called the team webinar, which is really focused on the didactic portion. And even when we have the didactic portion, we make sure to have some time for that peer-to-peer learning, which is another huge way that folks learn this information and begin to implement it within their own organizations. And then we'll have the peer-to-peer topical calls. And you know, the beauty of that set of calls is we'll wait to hear what topics of interest what the topics of interest are for the cohort. For example, you know, I'm hearing a lot about how did you document what matters, which is a question we have had since the first action community. So we can spend a dedicated hour talking about how folks have done that. Any challenges, any successes, any way to frame it when you're talking to leadership. So that's a really great call that focuses on certain aspects that the cohort identifies themselves. But yeah, so each month with the team webinar, we'll have our experts come and share about implementing each of the M. We do it in piecemeal, and then we have
Rahat, we lost you.
most likely the first time is you might need a few. I don't know why it keeps kicking me out. I'm so sorry. Can you hear me okay?
You're back. Yep.
Okay. Was that the part of the learning and action period, the circles? So yeah, each month you'll have the learning and action period circles where you have that opportunity.
Autumn, would you be able to join in? We've lost.
Yeah, I was just gonna say that I was trying to come off camera. Can you hear me okay?
Yeah.
Yeah.
Okay, perfect. I did just, Rahat, I don't know if you can hear, but I did just message you and say I'm happy to jump in here. But yes, so looking at the learning and action period, we did just wrap up our second kickoff call. Yesterday, actually, we had over 100 teams that joined us for the kickoff. But those were recorded, so it is not too late to join. We can make sure that you get those resources. But yeah, so this is an overview of the learning and action period. I know Rahat was mentioning that every month we have 2 sets of calls. It's the team webinar where we do a deep dive led by our expert faculty for each of the M's. And then we have a topical call that is based on the needs of the action community. But again, even though we did those kickoff calls, this is the perfect time to join. So if you go to the next slide, you'll just see an overview of some of the resources that are available to you. I know Marcus covered some of them, but thinking about how to build a case, building a case for age-friendly, calculating ROI based on your setting. One of the most important guides here is the guide for using the 4Ms in the care of older adults, which has actually been updated, and it's separated based on your care setting. And then also to that question of what matters, which, as we know and have said several times on this call, it's one you would think it's the easiest thing, but it's so nuanced. Sometimes it's hard to figure out, how to ask the questions, what questions to ask, and then how to document it and how to track it. So a lot of helpful resources available to you on IHI's website, ihi.org/age-friendly. And then on the next slide, you will also see um, well, on one of the other slides, we'll talk about some of the case studies that are available to you as well. And I know Marcus touched on this as well, and so did Rahat. But as you participate in the action community, you are working towards achieving national recognition as an age-friendly health systems participant, which is that first level of recognition which you get when you submit your 4Ms care description, which is basically your action plan. So you're going to take time in the beginning of the action community and that learning and action period 1 to assess how the 4Ms are already in practice in your care setting. As was mentioned earlier, we're not asking you to come up with something completely new. We're sure that some of these things are already in practice in your current workflows. The goal is to find a way to intertwine and integrate the 4Ms into the systems that you already have in place. So once you have built your team, which we talk about in the beginning phases of the action community, once you figured out who's going to be on your team, you'll work together to define your action plan. We know what the 4Ms are, but what will this look like in our setting of care? So once you submit that to IHI, they will either approve or temporarily deny you with some actionable feedback. So once you get that feedback, both IHI and AHA are available to do coaching calls to help you revise those care descriptions in order to get them approved. So once you have been approved for level 1 recognition and you are listed as an age-friendly health systems participant, you will then work towards achieving level 2 recognition, which is committed to care excellence. And you achieve that by submitting the count of older adults who've been impacted by that 4Ms care for 3 months. So in level 1, to achieve level 1 recognition, you are defining what your action plan or your care plan will look like. And then as you work to achieve level 2, you will be counting how many older adults have been impacted by that care. And then you'll achieve level 2 recognition committed to care excellence. On the next slide, you'll see some of the feedback, the great feedback that we've gotten from teams who've participated in our action communities. And on previous slides, and as Marcus has also shared, over 4,000 teams have joined this initiative. And thanks to them, more than 3,750,000 older adults have been reached by 4Ms care. And we get that number as teams submit their data for level 2 recognition. So that's why it's so important to make sure you're not only tracking for you and your team to measure impact, but also so you can share that data with us and we can measure the impact of this movement nationwide. So again, I'm not going to read through all of the testimonials, but they pretty much highlight some of the outcomes that they found for their team, for their patients, for their hospitals. And then it also highlights the experience that they've had as a part of the AHA Action community. So you will be in great company should you choose to register for the Fall Action Community. On the next slide, please. We'll see some more case examples, some outcomes. We did originally have Cedars-Sinai here in Providence, but Marcus, thank you for sharing your presentation. We saw that you included them. So we use that as an opportunity to also pull in some outcomes that we found from Advocate Condell in Illinois, right outside of Chicago, and Maine Health, as well as Atrium Health Mercy. So again, not going to go through all of these. Some of these are innovations that teams made. So creating dashboards, using a cohort enrollment and tracking system as they work to spread, and even some community partnerships here to help with their implementation and training of the clinical staff. But then you'll also see some qualitative outcomes as far as decreased fall rates, cost savings, decreased lengths of stay, et cetera, et cetera. On the next slide, please. You'll see some examples of case studies as teams are working in the action community and sharing their data. All of the action community facilitators love to learn about the great work that the teams are doing. And so we'll schedule site visits or listening and learning sessions if you're in the VA. Where we can learn about the great work that you're doing, which we then turn into case studies, which are shared with our networks. So you'll just see a few of them here. And if you're interested, I see some comments in the chat about outcomes. If you're interested in reading up more about them, you can find some on our webpage, which is aha.org/age-friendly. You can also check out IHI's webpage, which is ihi.org/age-friendly. Next slide, please. And there's a variety of care settings that are covered. So just make sure you check them out. I'm sure you can find something that is suitable for you. In addition to case studies, we also share the stories of our teams via podcasts, and we've had great success with those. And as you can see at the top left, we also experimented this year with a video format of the podcast. So you'll see Rahat there with Diane Mariani from Rush University Medical Center's Caring for Caregivers program. So there's a lot of great resources that are available to you on our website. Again, that's aha.org/age-friendly. Next slide, please. And also, please feel free to check me on time. I have no clue where we are, but feel free to cut me if I'm over.
We are a little over, but it looks like you're almost at the end.
Yes, I am wrapping up. And then also just wanted to share how AHA leadership is also supporting this movement. We've been fortunate to get a lot of chair files and then also have our CEO, Rick Pollock, who've released publications, and this is Rick's perspective as well that's listed on the left. Again, all available on our website. Next slide, please. All right, so if you are interested in joining the AHA Action community, again, it is not too late. We did do our 2 kickoff calls, but we have those recordings that are available to share with you. We also are launching an online community, so you can, chat with other teams and stuff in there. But yeah, it's not too late. I know you'll get a copy of these slides, which will include you'll see here hyperlinked, a link to our invitation guide. You can, and then also if you click the enroll today link, it'll take you directly to our commitment form. So I believe that's the last slide. If you do have questions, again, feel free to reach out to us via email at ahactioncommunity@aha.org. But other than that, I appreciate your time and attention and your grace with our tech issues this morning. My computer restarted twice, so I'm glad that I was able to make it through. But thank you, everyone.
Thank you for jumping in.
Of course.
Thank you, Autumn. Appreciate that. One last slide. We're a little bit behind schedule, but Dr. Parlunker will try to accommodate, and Nadine and Mary Jo. So we have Manisha Parlunker, who is the Director of Geriatrics at Hackensack Meridian. She is the co-director of the Center for Memory Loss and Brain Health and an associate professor at Hackensack Meridian Medical School. We have Nadine Benoit, who is a MPA and an elder life specialist and the lead program coordinator for the Hospitalized Elder Life Program, or the HELP program, within the Department of Geriatrics at Hackensack. And we have Mary Jo Phillips, a DMP Med-Surg, BC, as a network clinical program manager in geriatrics and May Center for Nursing Education at Hackensack Meridian Health. So I'd love to hear how Hackensack Meridian School of Medicine is handling the aging friendly. So thank you very much for taking the time and being with us and giving us this presentation, team.
Thank you, Josh. I'm going to share my slides. Okay, let me know if you're able to see them. Great.
Perfect.
I'm not going to be able to see the questions, so please feel free to ask, and I guess we could do that at the end. But this has been fantastic morning. What a best way to spend a Friday morning, and really looking forward to adding on to all the information that has been given so far about the age-friendly, the 4M model. As a geriatrician, I absolutely love this model. I love in making things simplified. I think the care for older adults is it is complicated, and it does overwhelm a lot of us. So giving this 4M framework has been excellent tool for all of us to have conversation, not just with our geriatric colleagues and trainees, but also with our subspecialties and our executive team. So really absolutely appreciate this collaborative. We are sort of going to be adding on to all the things that have been talked about so far, all the fantastic work that Hartford Foundation, IHI, AHA has been doing to roll out this the 4M model, and how all of us are learning from these initiatives from each other. So I'm going to talk about how we are taking this to across our network here at Hackensack Meridian Health, and of course, I've only put in 4 names here, but we really do have a village that's helping us with this incredible effort at Hackensack Meridian Health, and I appreciate a lot of them going beyond and above. So just to give you an idea who we are, I think a lot of you do know us. So we are a network across New Jersey. We are 18 hospitals. The mission and vision of our network is really to provide that equitable care to all people. And we are taking that mission and vision and adding to that 4M model as we started our journey and as we are improving and expanding our journey across our network. I think these stats are, again, all of us, these are already presented by Atlantic Health as well. Just to highlight that all of our hospitals are providing care to older adults, and a significant number of care of older adults. I've just, like, as you can see, we have highlighted some of our hospitals. They all are providing more than 50% of the beds are occupied by our older adults. And this is the crucial reason why we need to take the 4M model across, is because we are going to be taking care of them at all care settings. And unless we have that education and that framework, improving patient outcomes can get complicated, and this framework can help facilitate, make that complicated, intertwined multimorbidity care a little bit more easier for all of us. So again, these slides have been shown by, as you can see, we all share similar processes and similar mechanisms, that we all have niche, we all have gotten the GERI ED certification. We are working towards our geriatric surgery verification. Of course, HELP has been with us for a very long time. So what we have done here at HMH is that we really have taken this as a part of our quality improvement process. So not taking this as a separate initiative, but trying to embed that into all sort of quality improvement initiatives across the hospital, so we can provide that forum to any individual who hits any of the care sites. And now we have expanded our journey to our ambulatory care setting, and soon to be to our urgent care setting. So making sure that we do understand that our patient is in our center, and then utilizing the data, utilizing the QI network to get us that infrastructure and create that process. And really not putting this out as a additional work, but making it part of the framework so that it gets embedded and it gets carried on to all different processes. So that's been one of our asks. I mean, our executive sponsor asked us, what do we want to going forward? Our biggest ask was to make sure that the forum framework is included in any QI process that HMA starts. So really giving that central theme to this process. And we've seen this slide too many times, but I really like that the concept of shifting the care. It's not, we're here to make our patients better. We're here to make our system better. And if God willing, all of us make it there, hopefully we will have the systems that are age-friendly and that are providing that excellent care that we are trying to provide to others now. But hopefully we'll have the opportunity and to be able to see the benefits of this framework. Building on this is how we have carried out our message as well, is that how do we now align that with our US News rating? How do we align that with our CMS rating? And this is thanks to IHI slides, and we definitely borrow a lot of slides from the Age Friendly website to take on this message and to take this message across multiple sites. So giving this visual and speaking the same language has helped us gain that collaboration. So we're not necessarily just asking for a separate process, but we're here to help them to get to what they're trying to achieve in a systematic format. And I think that's been very helpful for us to gain that support from our executive team, from our quality improvement team, from our performance improvement team. So something to keep in mind for all of us, that we do have to speak similar language. If we speak different language, that's a barrier that we're adding already to our process. These are some of the things that we have implemented across HMH for our acute care setting. Again, something similar that Atlantic Health has already presented. So we have optimized our Epic. We are aligning with what was already existing as a workflow. So we really are working, we are interviewing our team on the ground on seeing what they're already doing and how we can align these forums on their current workflow without adding additional burden. And then how can we make it easily visible? And I will show you that slide as well. So it's easy to get to that information and easy to document that. So we have done a lot of Epic optimization to help us capture the 4M data, and then to be able for the team member to be able to see how are they doing with this 4M process. Medications, we have lots of different initiatives. I'm not going to read through entire slide, but again, it does require, I think electronic health records is a fantastic tool to help us. We want it to be a process. We don't want it to be a person driven. And I think that's what the EHR allows you, that it creates that reminder every single time for every single patient. And it doesn't rely on who is opening that chart. And I think that's been the big advantage to us too, since we are Epic across the network. It has really helped us optimize that across all our settings. To be able to do this and to be able to help our providers and our care team to do this in a systematic but a more user-friendly format, if you want to say. And we have added the lens of diversity, equity, and inclusion. We are working with our DEI team. We have added filters, and I will present that in a minute. We've added the DEI filters to our 4M data as well. And we just yesterday did a presentation to our DEI and our network team on how do we align with their their strategies and their goals in the framework of the 4Ms. And some of the initiatives that addressing the social determinants of health, as you can see, the Meds to Beds program that we have, and then giving the 4M education in multiple languages, keeping the cultural competencies and really utilizing all the resources and getting the help from the other team members as well. So I think that's really, we've talked about, we've heard a lot about what 4Ms are, how to get started. It really does help to, and as Atlantic had presented as well, it really does help to have that executive team support. So going to them right from the beginning and not as an afterthought has been helpful for us at HMH as well. And we are truly blessed to have multiple executive sponsors helping us move this forward. We have crossed the bridge of assessing, and now we are on our journey on Act On as part of the IHI initiative on how learn and teach approach on network implementation. We are part of that project right now, and we really are now moving on from assessment to Act On, and how do we make this a more active intervention versus passive intervention, or versus just data gathering. So this is what I was talking about our EPIC optimization. So this is our summary, which pulls data from all the different things, and that's the 4M dashboard. And we have this available both in acute care setting as well as an outpatient setting. So it's a quick way for the team member to assess and address any deficiencies in the 4Ms. This was just recently rolled out, so we are looking forward to now gathering feedback from our team members about the utilization of this and how does it help them in their day-to-day practice. So excited to continue to improve our EHR to support our team members. I saw a lot of things in the chat about lack of resources or limited resources. And I think that's across, that's not just one organization or one program. So we will all have to figure out how do we optimize the resources that we have, and how do we automate some of these that we can utilize easily. And this has been a helpful tool. And how has that helped us in improving some of the outcomes? As you can see, one of the M's with the mobility, it is by putting together a lot of different processes at our Ocean Medical Center. We have shown consistent improvement in the mobility initiative. Adding the DEI lens, we have increased our med to bed utilization. That all of these interventions are helping us move the needle in the discharge to home. It is helping to capture the data on medications more accurately, so we can create our quality improvement processes around that. Aligning that with the quality initiatives, aligning that with our 30-day readmit, length of stay, HCAHPS. So really working together rather than a silo has been beneficial for us. And now we are getting invited to all of these committees, where we now will be talking to our Chief Quality Officers Committee soon. So really working with, and of course, the new CMS initiative has been a blessing now. This will really allow us to move the needle even further. I just received an invitation to come and talk about what all things we're doing and what we already have in place to align ourselves with the 2025. The ED initiative, adding the 4M framework for our GRE ED accreditation, again, helped us capture the baseline data and has really helped us build on. As you can see, the progress has been significant and consistent. It also allowed us to do problem solving when we were struggling with our delirium triage screening in our ED. By using the CAM and the Minicog as a tool, we realized that we were not optimizing the ED process. So we created surveys, we talked to the team, and now we have a different tool. Now we are using a delirium triage tool versus which is a more ED friendly tool. And as you can see, that has significantly helped us improve our delirium assessment. So I think that's one of the things that having the quality improvement process, it forces you to think outside the box. It forces you to do that problem solving, and then it allows you to get the results that are improving. And then it allows you to add the additional layer. Now that we have achieved more consistent screening, we are moving on to looking at how a prescription on inappropriate medications can impact the delirium, and then giving real-time feedback. Of course, we know there's plenty of data and evidence base that medications are a significant reason for delirium in a hospital setting. But I think providing that real-time feedback to that provider that, okay, this is what happened to your patient, can be a very powerful tool. And that's the journey that we are heading towards, is that how do we give a provider level feedback in addition to giving the evidence base, and in addition to providing the literature and the data that is available, so readily available now for the benefits of these 4Ms. I think giving the provider-based data would be very, very powerful for us. So we're going to continue to build on. This is what we are challenging ourselves, is putting all this data together, keeping DEI always as a part of the process. Whether we are building dashboards for ourselves, or whether the DEI team is building the dashboard, we are keeping this as a centerpiece. Working together, working with our DTS team to helping us gather this real-time data, getting more specific in chronic conditions and key outcomes, aligning that with our health literacy, and improving the cultural competency. So embedding that as part of all of these, and getting help of all of these to make sure that the 4M care is stronger and effective. Okay. Our Network Geriatric Council has really been a true powerhouse to connect with a lot of different programs across our network. We are offering mentorship, we're offering expert opinions in various programs that are happening. One of the big ones that our pet project for us right now is improving the sleep assessment. And our program is called Rest Assured, improving sleep hygiene in the acute care. So we're taking this on the road, utilizing Epic and making us improve care around the sleep medications and sleep hygiene. So lots of different initiatives working together, building with each other rather than duplicating or working in the silo has definitely been a big theme. And making sure that we celebrate our team members, we celebrate their achievements, how small, how big. So giving that, it really, and encouraging them to go out and submit for posters and abstracts, so people learn from us as well as just like we are learning from them. Is something that we are encouraging in our every meeting, and helping also, not just encouraging, but giving them the resources to be able to do that. So working as a team, working together as a village rather than silos has been very helpful for us, and in continuing our journey. We started our journey at HUMC in 2018. And now we are across our network and building more. And as I said, moving on to now urgent cares as our next project, and also working with some of our nursing homes in the area to see how we can take this into the nursing home setting. Before I stop, I also want to give a big shout out, since we've talked a lot about geriatric workforce and lack of geriatric workforce and geriatric education. Since a lot of us are here, Josh, Kirti, sorry, David just dropped out, but and Kevin, a big shout out to our New Jersey Geriatric Consortium, which is a geriatric fellowship consortium across New Jersey, where all 6 programs come together once a month to help improve care. And of course, we use age-friendly model a lot in our talks for training our fellows, our residents, and our students. So definitely a lot of collaboration, not just across individual network, but also across New Jersey geriatric programs has been very helpful for us to learn from each other. Thank you, and happy to take questions.
Thank you. I have a question for you, and I think it was in the chat as well. You had 2 slides about prescription, and I think you explained it in your second slide, but at first it looked as though the number of medications increased. Was it the actual number of medications, or was it different, more appropriate prescriptions?
So this is it's capturing the data around number of medications. So that's the reason why we wanted to see the increase that now we are actually seeing that we are able to capture the data better. So this was improving our data capturing process. Yeah. And again, this is not unusual. This is the trend, right? We are seeing more and more prescriptions for older adults. And they are going to continue to increase, especially since Part D had gone into effect. There's lots of papers that has actually increased the number of prescriptions for older adults.
Thank you.
Well, Manisha, you guys are cutting edge there, provocative and innovative, right? And so important for the health of New Jersey. It's a public health issue, really getting out there to nursing homes, to urgent care centers, to hospitals, and really the whole health system. So really inspirational. And here to you as well, Atlantic, you know, also really cutting edge. So I admire what you've been able to accomplish. And down here, we're doing our thing down here too, in Central State. So
we do have an ACE unit, and starting off the unit that you spoke about, Kirti, Dr. Parulkar, it's really heartening to see what great progress you've made since 2018, and Dr. Kirti Sharma since 2019. It kind of excites us and inspires us that we can start and accomplish so much with your help and collaboration. I look forward to our collaboration in future as well, along with the John A. Hartford Foundation and NJAAW. Thank you very much, everybody.
Thank you.
Thank you. I think all the questions in the chat have been answered. If anybody does have other questions, you can email me, and I will pass them on to the speakers. But I want to thank everybody for joining us today. And it took us months to set up a schedule where all the speakers were available. And I appreciate your time. I appreciate all of you who have come to join us today. And I really hope that we can move the needle on this in New Jersey.
Absolutely.
And thank you, everybody.
Thank you. Thank you so much. Again.
Thank you for the opportunity. Yes, thank you for a great morning.
Great.